So I'd like to talk about what you've been doing at the Texas EMS Alliance, because you've been doing some of this stuff for a few years and you've had some really big wins over the last few legislative sessions.
Our goal and our promise to the legislature for the funding was that we would add another 2,000 people to the EMS workforce. We added 10,000 people to the EMS workforce within about a year and a half.
Well, welcome to another episode of the Leadership Lab. Glad that you've joined us, and I'm really excited to have Butch Oberhoff with me today. Many may not know this, and some of you may be listening in here for the first time or watching and don't recognize who you see. But I've known Butch for many, many, many years now. We're all getting older in the industry, in the healthcare industry. And so you realize, like, something like thinking it's 5 years ago, Butch, but we've known each other a while. But I want him to introduce himself. And then we're actually going to talk a little bit. It's going to be about healthcare, specifically in the emergency medical services space, but also in this continuum of healthcare where unplanned, you're hearing us talk a lot about unplanned, unscheduled healthcare. And this is a nuance and a niche that we've been in. So, Butch, introduce yourself to some of our audience.
I'm Butch Oberhoff, and I live in San Antonio, Texas, but I feel like I spend just as much time in Austin as I do anywhere else. And although I am a native of South Louisiana, I'm one of those folks that said I got to Texas as soon as I could get here. And my employer is Acadian Ambulance Service. I'm the Senior Director of Governmental Affairs at Acadian. But the other important part of my life, I guess, professionally, is the current president of the Texas EMS Alliance, a group I'm very, very proud of. And I'm so proud of a lot of the initiatives that we've worked on since the inception of the organization, which is just over 10 years now.
And I know that because my background, of course, is in EMS. And so we're going to mainly focus this podcast around EMS, but more around the collaborative nature. And sometimes, and this just isn't in EMS, it's in healthcare in general, sometimes we get caught up in silos, and things don't move as fast as they would move if we would collaborate. I would love to see a lot more collaboration amongst the healthcare in general, amongst the payers to the providers and what have you. But let's talk about what we can control in EMS. And you've been doing some yeoman's work here as an industry here in Texas. And you've been moving the needle on some things that some people just thought was not even possible. And so I want to talk a little bit about that today. And there is a portion, so we're going to dive right in, Butch, but there is a statement that I've been talking about for several years about the rising tide lifts all boats.
Absolutely.
And I'm loving to see it. For instance, I see that in California this year at their annual conference with the California Ambulance Association, that actually is their theme this year, the rising tide lifts all boats. And I'm loving to see that we are beginning to recognize, not just in EMS, but in overall, about the need to have collaboration. So I'd like to talk about what you've been doing at the Texas EMS Alliance, because you've been doing some of this stuff for a few years and you've had some really big wins over the last few legislative sessions. But for those that do not know, that may be listening from a different state, talk a little bit about how the legislature runs here, because it's not generally how some other states do. So talk a little bit about that, because you have a finite window of time to get stuff moved. And then you have to wait a few years. So talk a little bit about that, and then talk about what you guys have been doing over the last several years.
Okay, so you're right. And I think that the founding fathers of Texas, before there were cars and airplanes, were so concerned about the travel time into Austin that they decided to only have the legislature meet every other year. So for 140 days, starting in January, every other year, we have whatever opportunity we have to pass any legislation. And I will tell you that Texas files more legislation by far than any other state. I think this past session, there were over 9,000 bills and resolutions that were filed. And I think California was the only state that even came close, and he was still maybe just over half of that. So some folks would say, well, that's because we meet every other year. But I really have begun to believe that it wouldn't matter how often we meet. It would still be a large number of bills. But it's a lot of work and it's a lot to follow. And you know, you talk about collaboration and getting out of silos. The Texas EMS Alliance was was founded, and our board makeup was very intentional to include every provider type of every size so that everyone had an equal voice.
And when you mean about every provider type of every size, what do you mean?
I'm sorry. So EMS in Texas, as in many other states, can be made up of private companies and fire-based EMS agencies and hospital-based EMS agencies, nonprofits, third service. There's all these different types of providers who probably prior to TIMSA all sort of worked in their own silos. So when we got together to form the group, the founding members, and I give a lot of credit to your friend and mine, Dudley Waite, who's now the chief of Fort Bend County, he said, we have got to stop fighting over the 20% of the things that we probably won't ever agree on, and let's focus on the 80% of things that affect all of us. And following that mantra and working on how do we help that tide lift all our boats, we've done some tremendous work in Texas, and we're very proud of it.
Yeah, and I will tell you, Butch, because I want to talk a little bit about that for those that are listening, because sometimes I've heard, being in the industries or whatever, well, but wait a minute, this group is trying to do this, and this group is trying to do this, and Dudley Waite was so right, saying, there is probably 80 or 90% of everything that we agree on. Let's leave the 10%. Let's move it. But the way that you guys constructed the board, everybody has an equal vote. Yeah. There's not some that just are a part of it but don't have the ability to impact policy or what have you. You guys have set this board up very intentionally to make sure that everybody feels like they have a inclusive vote. Even if you don't vote on some of their stuff, people at least are heard. Is that correct?
That's absolutely correct. And I will tell you that we try really hard on any initiative to get to a unanimous vote. And I can't even remember a time when we did not. And I think if we can't get there, then we keep trying to work toward that. Okay, well, how do we make it so, even if a majority rules, the people who don't vote with you are not going to be on the team. So let's try to work until we can get everyone on the team. And it's worked very well for us.
So to that point, let's kind of talk a little bit about what you've done. And I know one thing that you've done, and I want to move in, and we're keeping this focus to EMS. So to all my friends that might be listening that's not EMS, I get it if this doesn't interest you, but just pay attention to the concepts maybe. But let's talk a little bit about EMS around the workforce shortage and the funding that you were able to procure. Like, I think it may have been one of the first in the industry or similar on a state level where you're able to kind of do some things around this workforce, and this happened several legislative cycles ago. But talk to me about how that actually happened, what you did, because it was really a big win for the state of Texas and the EMS industry around some of these.
It absolutely was, and I'll tell you, it came because our board, we're all in a room, and I remember the room. We were at our annual conference, and there was a lot of funding that was available through the ARPA funds because of the pandemic. And we, at that time, Texas was spending about $26 million a day on nurse staffing, which is certainly important. And this is not a criticism of nurses. I'm married to one. I know we need nurses. But EMS was left to fend for itself. And we were struggling. And so we said, well, we really ought to ask, since there is some available funding and they seem to be looking for the right places to put it, let's tell our story. And I say that over and over again, tell your story, tell your story, tell your story. But we knew better than to just come up with a number out of nowhere and go demand it. For one thing, the Texas legislature won't tolerate that. You have to come prepared, and you have to come with data. And if you are going to ask for money, you really should be prepared to explain in some pretty significant detail how you're going to spend it. So we asked for them to partner with us in a workforce development effort that included some recruiting, which that was hiring a professional public relations firm that understood marketing and understands targeted marketing through social media and what have you. I mean, when I was a young EMT, you'd probably put something up at a movie theater, and now it's all social media. So we had to work through that.
I want to stop you there because I want people to pay attention to what you said you employed. Now, outside of just data, You talked about the data, whatever, but you said we first had to tell our story. So we hired a PR firm.
Yes.
Who better to tell your story that knows PR, that knows how to tell stories than PR and marketing firms?
Absolutely.
And I am literally, I think one of my first podcasts that I've talked about this was the whole story branding concept. And I had aha moments when we as a company hired an outside marketing firm that came in here. And I'm like thinking, you have got to be kidding. Aha moments. This is the problem is we think we know because we went and watched a YouTube video about it. We went and read an article and now we're the experts in but there is actually an art to it. I have an aha moment with me right now talking to you. I didn't realize it's what you guys did. So it makes sense to me why he had such huge success on this initiative.
And we worked so closely with the state office, the Department of State Health Services, and the state EMS director, who was a terrific partner. But I told him, I said, no offense, this can't be some intern in the basement of DSHS. We need to hire a professional group that knows how to do this. And I will tell you, we learned so much from those folks. They brought in focus groups and Texas is a big place. And what's important to people and what resonates with someone in the Valley may be very different than in Austin and very different than in West Texas. So they helped us understand and appreciate what would resonate with these people and what will resonate with a 19, 20-year-old career seeker and what will resonate with a 32-year-old person who's wanting to find their final career. It was extremely valuable. And then they are so scientific about the social media marketing process. And I fussed one time, I said, I haven't seen one of these things come across on my social media. And they said, well, if you were seeing it, you should fire us because you're not who needs to see it. Point taken. But in a state of about 30 million people, within the first 3 months, we had 50 million hits, and people were on it. And a lot of this is Greek to me, but it was a phenomenal success. And our goal and our promise to the legislature for the funding was that we would add another 2,000 people to the EMS workforce. We added 10,000 people to the EMS workforce.
And what time frame was that?
Within about a year and a half. It was tremendously success. And the sad thing is we still need more, but that's a huge win. And that really shows you that was a great investment of those dollars. And I'll tell you, so we spent some money on the PR firm. We spent some money on some resources in the website, but the bulk of that, it was $21.7 million. And EMS had never been trusted with that kind of money before. And we knew if we didn't do this correctly and if we weren't accountable, they'd never trust us again. So we really went out of our way to make sure we were transparent and very accountable. But about $16 million of that money went directly to scholarships for EMTs and paramedics and advanced EMTs. And the only qualifier was you have to work on a transporting EMS agency. We didn't get in the weeds with all the other qualifiers and your income level and your this and do you have dependents and all that.
Made it simple.
Yes. And you are committing to work on a ground transport EMS agency. And it was tremendous. It was so successful.
So let me ask you that because I want to go back to you kept it simple. And sometimes I wonder if sometimes why some of our initiatives aren't making it through is because we make them so complex. It's hard to tell the story to the legislature. So you kind of kept it simple to where everybody could qualify and you just show data and I had to show outcome of what the dollars were going to.
And I think that the other value of simplicity is that when we said we will use this money to do this, it was very clear. We will pay for tuition for these programs. We didn't complicate it by making it a slush fund. Oh, and we're going to pay for wraparound costs and we're going to pay for this. And all that stuff can be valuable, but this was a one-time funding and it was a huge ask for EMS. So we didn't want to muddy the waters. We wanted to say, we will spend it on this and we could come back and show you this is what we spent it on. Trying to make it too complicated or making it, I guess, muddying those waters where they're really wondering, does the money really go where it was supposed to, or did you somehow find a reason to use it for some administrative costs, or did you do this? No, we wanted it to be clean.
And the one thing that I'm hearing here, and I'm hoping everybody's, as you're listening here, is you really should apply. We hear it a lot. We hear the KISS method. Keep it simple, stupid. And oftentimes we complicate something. So generally when you do your blueprint, keep it simple. Many times people want to run to the detail. You haven't even sold your blueprint or what have you, and you're already in the weeds and the detail, and you haven't even sold the blueprint. And that's what you did here. That's what you were advised to do. That was like, let's just keep it very simple. Let's just win.
Yes.
And that's what you did through that piece of it. So if you're listening today and you're wanting to know how to do it, hey, Butch, maybe we'll leave him and you'll get his email after this. We might try to twist his arm, but he'd be the right person to talk to. Let me switch a little bit on you. As we're talking here, I want to move to more of EMS, our EMTs and paramedics, about being more about in the healthcare continuum. Many times we hate it when people refer to us as ambulance drivers. That I know that is literally, that is a pain point for many when they hear it. We still hear that, ambulance driver, but we really are healthcare practitioners. We are healthcare clinicians. We're not pre-hospital healthcare. You are a healthcare practitioner. And it's just that simple. I was telling that to somebody last week because they were saying this. I said, you simply are a healthcare practitioner. Own that. I don't care at anybody. That's what you do. And to that point, you guys did some stuff. This has been an initiative that's been happening across the nation around blood, paramedics being able to do blood. And I know there was a very specific initiative in Texas recently where you guys tell us a little bit about that, what that process was like. You guys had some success, but you had some aha moments during committee, things that maybe people did not realize. And that's what I really want you to talk about to our audience.
That was exciting. And Texas is a very conservative state. We have a very conservative legislature. So sometimes you have to, read your audience and think about when you go to ask for something to benefit the industry. If you're in a Chinese restaurant, don't go looking for lasagna. You better find something that will match the audience. And that's a silly analogy, but it is true. Well, we know things like Medicaid increases, that becomes very difficult to do in Texas, but they are very keen on workforce issues. They're very keen on saving lives. And we know, unfortunately, we have a lot of deaths on interstates in Texas. And we have some deserts for healthcare and all this. And when we knew, especially in the San Antonio region, and it spread across, but in the San Antonio region, they had been working on this initiative for whole blood, and University Hospital in San Antonio and their blood bank was a big part of it. The blood provider and then the EMS entities kind of all got together, and they worked out a way where not only were we really showing great outcomes, and look, there were tons of data to show that we can save lives. Of course, trauma patients, but also maternal patients, GI, maternal OB and GI patients. So it was more than people expected. And the results were just tremendous. And we even found a good way, and I say we, I had almost no part in it, but the folks down there found a way to not waste any blood. So it's out in the field, it's ready for use, but when that blood, which has a life cycle, and when it would get within 2 weeks or so of expiration, it would come back to University Hospital where it would probably be used the same day. They would check it out and all that, and it went right to work. A fresh unit of blood was replaced in the field. So, because we knew we wouldn't get any support if we were wasting blood. Well, they've gotten down to just about a zero waste. So that important resource is not being wasted. It's being used like it should. And so when we went to the legislature and said, we'd like to expand this program a little bit, and our board talked about it a little bit, and who should really tell that story? Should it be an EMS provider that, someone might wonder, well, is it just a money thing, or what are they trying to accomplish? So we instead decided to let the physicians who are involved in this program be the mouthpiece and to testify in those hearings. And Dr. Kidd and Dr. Winkler and Dr. Jenkins, who was the architect of the whole thing at the trauma center down in San Antonio, they were ready. And they had their own data, and I can save this many lives. If you can keep these patients alive long enough to get them to the hospital, and whole blood will do that, then we can save more lives, and we can save OB patient lives, and we can save GI patient lives. And it was strong testimony. And some of those hearings, especially when it's healthcare issues, they can go, 12 hours, 14 hours. And I think we were probably on hour 9 or 10 before the docs got a chance to testify on this issue. And I feel sometimes for those state senators who they're there all day listening to this, but when they heard about what whole blood could do, it immediately got their attention. And the chair of Senate Finance, to her credit, she had a few questions, and the chair of Health and Human Services were in the same room, and apparently they had already been talking about how do we save more lives on our highways in Texas. Well, our docs had a good answer for them. We went in asking for $4 million to expand the program. On their own, they upped it to $10 million. So this is exciting. That gives us an opportunity because you can't carry blood around in an igloo or a Yeti. There's a lot of equipment and monitoring it, or whatever. It's expensive. But this allows us to put a lot more of those systems out there in the field and then funding the blood so we can continue to do the great work we've been doing.
This was the one thing that resonated with me when I heard this, when we were talking and you told me, man, we were only asking for 4. And after they heard the doc story, what they said, they gave you 10 million.
Yes.
Over double what you had asked for. And this is what I want the audience to hear. This is what we keep talking about is, Butch, you weren't at the table and you're smart. You understand policy, but you knew enough to say, we have to have the physicians at the table telling the story. And many times we are looking for something. We're trying to tell the story, but we have the wrong mouthpiece. We have the right message, but we have the wrong mouthpiece. And that is what we have to do as an industry to begin to understand. We want to make practical change. And I don't care if this is just in EMS. This could be anywhere. Do you have the right people at the table? If I'm talking about something, there are many times I don't need to be at the table on any of this. And I'm not. I might have a conversation behind the scenes, or I might go somewhere else to do something, but I'm not the mouthpiece on this. This is going to be, if it's something about quality outcomes or whatever, I want the data folks. Where's the data? I want the data people that can give me outcomes, physician, clinicians. I might understand all the financial reimbursement side, how to write the policy to make it work or not. I'm not there to tell the story. The story needs to come from a source that people can understand. That's what happened there. That was the biggest lesson that I learned, because that is unheard of.
It
for
is
you to get more than what you're asking for.
A lot of times you ask for 10 and get 4. It's almost never, in fact, no one can ever remember asking for 4 and getting 10.
Yeah, I'm like literally sitting here thinking, I don't think in all the times I've been doing policy, so when you did, it resonated with me. I'm like, it's not the message, it's who is telling the message.
And you can't let egos get in the way of who the right messenger is.
Yeah.
And then, of course, now my message,
of course, there's some physicians I would never have at the table because I love them all to death or whatever, but some of them have an ego this size and they don't listen to anybody, and that's not a right whatever. So it would take the right messenger with humility.
Sure.
And I know what you're saying. Like, you got to have a messenger that understands the art of humility.
Well, I didn't want to let my ego get in the way and think, oh, well, I'm the president of 10. I should be. Oh, no. It needed to be the right people. And, in the House hearing, there is a physician on that committee, and he's an anesthetist. Anesthesiologist, excuse me. And he is a very sharp, very knowledgeable. The guy's an expert. And so when he had true medical questions, And the docs were ready for that too. And I don't think anybody else in the room even understood what they were all talking about, but it didn't matter. And I think that the rest of the committee kind of looked at him, and when he kind of gave it the thumbs up, in fact, he offered to carry that budget rider on the House, and we thank him. Dr. Oliverson is a state rep from around Houston, and it was great. So, and then, of course, after that, our messages to our EMS agencies who are excited about doing this. Okay, folks, here again, we've been trusted. Now we're going to have to be accountable. So to the folks who are smarter than me that are putting that program in place and developing it and growing it, we will be able to come back with very specific data that said, this is who got blood, and this is,
this is the
and it's very simple. What you provided this much blood and this much, this many kits to carry all this stuff. And that's really, really important. If they trust you with something, you really need to be accountable for it, especially if it's public money.
Yeah, especially when they gave you more than what you asked for.
Absolutely.
And so now you have to make sure that you have the data that can provide the outcomes that they need.
Yes.
And that's what I'm hearing with your story that you had about workforce shortage stuff. You had data.
Yes.
Coupled with the right PR message. Now you've done the same exact thing and you're having wins. And so generally when we start to see this, people should start paying attention. It's the reason why we're talking today, is because I want them to hear it directly from you. I think you have a subject matter expertise in certain ways of looking at things that it needs to be heard. Like, it's not just us saying something, we actually have done it. And we've not only just done it once, we've done it twice, which I'm going to now revert back because I want to spend a few minutes on this because this is everybody's discussion point right now. And surprise billing has been a big issue. It was actually taken care of with all other specialty types when the when we passed some legislation, or the No Surprises Act, at the end of 2019. It was implemented through the process, but of course, ground ambulance services were not included. That was remanded to a committee to take a look at. I was a part of that committee. There was a modification, or there was a recommendation given to Congress what to do, but there still has been nothing that's happened on the federal level. So states are taking it upon themselves to try to enact something. While it may not cover all lives that are covered, because any state law only governs that, which is covered by state law, which is in Texas, for instance. It's only like 15% of the covered lives here. But talk about a little bit about what you guys decided to do. You guys did a few things. You did it through in your part-time legislature. You guys started to do some things and had some success early on that kind of shaped a little bit about what some of the other states have been doing. I want you to talk a little bit about, because there's another success that you guys, and it's not on the clinical side, it's not on the education workforce side, it's now more on what I would call the healthcare finance side, as it's dealing through the eyes of the patient. So talk a little bit about that piece, because this has been an ongoing process.
It was, and I'll tell you, this is another example of collaboration, and I really want to give credit where credit is due, because there was a lot of finger pointing back and forth, and the patient was stuck in the middle, invariably. And it was emergency transports. It was non-emergency transports. A patient who had, and I love this term, well, I have good insurance. Well, you probably do for your surgery, but maybe not so much for ambulance service. And, we tried different ways to wrestle that bear for a couple of sessions. And I think it finally wound up with a study. And the study came back, and Texas is pretty much like the rest of the country. Only about 14% of ambulance transports were handled by an in-network ambulance service. Well, when that study finally came out, the legislature no longer cared whose fault it was. They wanted it fixed. And so and I give a lot of credit to the Texas Association of Health Plans and Jamie and her team. It was collaborative, and they said, okay, we're all waiting for the feds to get around to addressing this. And I think we can all agree we'd like one system and not have two systems for state-regulated health plans and the ERISA plans. But until that comes, let's agree that locally set rates are going to be important, and we understand a lot of Texas is very rural. Those locally set rates are sort of key to keeping an EMS presence even in those counties. And I hate to be so dramatic about it, but it absolutely is. So we'll say locally set rates would be in network, and for those communities that don't have locally set rates, where an elected body hasn't met in a room and voted, then we'll just say the default will be 325% of the prevailing Medicare rate. And then the EMS agencies, you can't bill beyond that. That's what your reimbursement will be. That was a very fair deal, we felt like, for our providers. It was a very fair deal for our communities, and it was a great deal for the patients.
And there was a reporting requirement too, right? Didn't they have to, if you had a local rate, you had to report it?
And that was sort of the thing. Well, how do we even know? And to their, I mean, honestly, the health plans, they said, really, how are we supposed to know? Texas Department of Insurance created a database, and it's public information. It's on their website. And we submit, or our governmental entities submit rates that are loaded on the database, and the health plans check with that database before they pay any claims.
So basically, if you have a locally set rate or a local rate set, whether you're contracted with it and your rates are set, so you're a private entity or hospital-based entity or governmental entity, you have to report your rates to this database at the Texas Department of Insurance that anybody can access. The public can go in there. You that are listening right now, if you wanted to, you could go check everybody's rates out if it's locally rate set or whatever. But it was a one component, and that was to help the insurance plans to be able to implement that.
And it applies to emergency and non-emergency ambulance transports. And Senator Zaffarini and her office helped us put it all together. And it's been really successful. And most importantly, it's taken the patient out of the middle, which is what we all wanted.
Now, there was a very interesting thing, because the first time it was implemented, it sunsetted after 2 years. They wanted to kind of take a look at it, correct?
They wanted to take a look at it. And there was also, in the event the feds had gotten around to a broader rule, they wanted an opportunity to just fold into whatever the federal rule would be. Of course, 2 years, there's no way that was going to happen that quickly. So in this past session, we renewed the bill for another 2 years. It's essentially the same. We, in good faith, we included some language with some teeth in it. If for some reason an EMS agency, even after being notified and warned and all that, would choose to break the rules, then there's some teeth in it. Some enforcement language.
But so there's some enforcement language that may have not been, that was not in the original bill.
Right.
You now have some enforcement language now.
Right. And it's never been used.
Sure.
Everyone's following, occasionally there's a mistake, but it's usually just a clerical error. You notify.
Generally speaking, how has the EMS community, as an association president, have you heard any issues that there have been from your members that have had issues with this legislation that was passed? Has it been pretty easy? Have they seen compliance by the payers? Because I know in some states I hear there's major issues. I mean, I could list states, but I'm not going to. But there are some states where there's still lots of issues even after passing state laws.
In the first few months, but health plans are made up of people, just like EMS agencies are, and it was a big rule. So there was a brief period when we had to kind of remind them, this is a new rule. TDI's got all the information. There's the database. There was a period when EMS billers had to learn, oh, wait a minute, this is different. I can't balance bill and all that thing. But honestly, after the first few months, no, it's been really smooth. It's worked out well.
And that could be something to that, 15%. But a lot of times we're seeing compliance across the board with payers on all, depending, whether they're under ERISA or not, they're still following the rules or whatever.
The biggest challenge is just identifying those patients that are under state-regulated health plans. And the Texas Association of Health Plans understands that concern, and we're still trying to talk about a better way to identify those. But no, honestly, and it was a very good deal for EMS agencies. We feel like it was a fair deal for the health plans, and ultimately, it's the best deal for the patients, and that's what we all wanted to get to.
And the one thing is that there was a collaborative effort between the EMS industry and the health plans,
yes.
correct?
To be completely clear, there is no way we could have gotten that accomplished without the collaboration with the health plans. So we're
And I'm
grateful for
hearing
that.
just a general theme of what you've been doing for the last several years has been, we understand the rising tide lifts all boats. And that is collaboration, not just amongst our industry, but amongst the healthcare industry in general, including the payer community. And I like that that's the mantra that you've set. And you've had several successes because of that collaboration. You may not have gotten everything you've wanted, but you've been able to get to consensus. And that truly is, I'm not even going down the political realm, but we're both in politics. That generally is where we need to move to as a nation in general, is consensus. I'm not going to always get everything. Like they always said, the best legislation passed, or the best thing is like everybody hurts a little bit. You know what I'm saying?
Absolutely.
That's probably the best. That's when you know you've got a really good piece of regulation, is because everybody hurts a little bit on that. I want to end with this as we're coming down to the end. And the thing that most people is on the forefront in healthcare's mind in general is some of the provisions that were passed in the One Big Beautiful Bill. Or what we're calling OBA now. So the One Big Beautiful Bill Act. It's really hard to say a lot. So OBA, I'm going to refer to it as OBA. I'm doing a webinar, and by the time people hear this podcast, the webinar have already passed. So you can, of course, go to my website and see a review of that. But we're going to be talking a little bit about this provision. But I want to understand what you're hearing here as the president of the Texas EMS Alliance, what concerns that you might be hearing from some, because there's concerns. To me, I'm looking at it from more of an optimistic view. That's what my podcast is going to be. I'm going to do it with a different spin because I think there's a lot of opportunity for EMS. I can focus on the concerns that I have, or I can focus on the opportunities that are in the bill. But what are you hearing, generally speaking? A lot of people are starting to prepare a little bit. I mean, it's new. I mean, it just passed on July the 4th. There's a lot of detail in there. There's a lot of potential impact. There's timelines that go with it of delayed. I mean, I can opine on that for days. That's going to be a whole different conversation that we're going to have. But I really would like to hear from your perspective. As we're starting to move into these new waters of OBA, it's probably the most comprehensive healthcare package that we've seen in a while. What are you hearing from some of your members? And
you know, the knee-jerk reaction, because Texas already leads the nation in uninsured patients, and so that's a scary thing to think about. But to the point that you open up with, where the old model where we just go and take everybody to the hospital, that really has to change. And maybe this is the impetus, because we can do so much more. And during the pandemic, we really proved that. You know, and there was the ET3 model, but that almost got preempted by just necessity, where we had overflowing ERs and medics were taking care of people in their homes, and we were creating hospital at home programs, and we were caring for those things, and whether you call it community paramedicine or mobile integrated health or whatever, and the definition of both of those sort of broaden extensively. I think this is where we're going to need to demonstrate our value to the healthcare spectrum. We have to get away from this where our model is to take everybody to the hospital. These people are highly trained. And they can work in concert with RNs. I mean, my goodness, my wife is a nurse practitioner, and they work nurse practitioners and physician's assistants. They're both mid-levels, but they manage to work together and occupy the same space, and they do great work for patients. And I think that there is an opportunity for paramedics to stop always being associated with lights and sirens and become field clinicians. And I think so much about rural Texas, where it's a long way to a hospital, and what a disservice to take somebody. And I'm not exaggerating. If you haven't driven through West Texas, an hour and a half, 2 hours to a hospital that we could care for them at home. And what a blessing that is to their family members, especially older patients. If we can care for them there, and they're more comfortable, and they'll do better, and they rest more. That is the model we need to be working toward, in my mind. And it'll take some tweaks along the way, but really turning our folks, our EMS professionals, and maybe we need a new title, but will they truly become field clinicians, community clinicians? Will they care for folks? I really think that that's where we need to head, because it's much better for the patients. It's way less expensive for the payers, and that's got to have to be considered. And it's less of a strain on some of our hospitals. And if you have been to a hospital in a big city, you see the ERs are just overflowing with people, but they're using it as primary care. So I think that there's an opportunity for us.
And I think the healthcare community is waking up to the unsustainable spend that's happening in healthcare in general. And I don't care if it's whatever the payer is, whether it's Medicare, whether it's Medicare Advantage, whether it's Medicaid, and we can all point fingers and say, well, there's a lot, and we know there's a lot going on with fraud, waste, and abuse. That's one area. But also, if you see a trajectory that's unsustainable and you keep doing what you've always done, what do they say? You will get what you've always gotten.
Right.
And so unless we do something disruptive, and I like it that that's what you're hearing, that's what people are talking about, because if people that are listening today would go back and listen to the very first episode that I did on the Leadership Lab, and I did it with Dr. Eric Beck, the CEO of ESO. And ESO right now is the only data in our industry right now that has a longitudinal record of about 40%. There's others that have some, but nothing at that scale yet. I've got friends such as Jonathan Fite, who does a lot of work in his group, and they're doing a lot of work together. He's from California, very vocal. If you don't know him, go follow him. He likes to keep things stirred up a bit, and I like that he challenges the norms and the story that we tell and who should be telling the story. And so Dr. Beck will be on my podcast again in about a month, because there is something about the continuum of where we are, and that is the unplanned, unscheduled part of the healthcare continuum. There is no one else in healthcare that can do the unplanned, unscheduled like EMS can, because we are 24/7. No one else can. Now, there are some others that they can, that may not be unscheduled or unplanned, that they can get to. It might be planned care. But there is a nuance here that we can provide to the healthcare continuum. And there is money that's in OBA that has been appropriated to looking at things around the Centers for Medicare and Medicaid initiatives and their Make America Healthy initiative again that they have coming out. They're looking at outcomes. How can we impact stuff? Get people before they ever need to access the hospital. Hello, EMS. I mean, if we're doing social determinants of health, even then we didn't even realize we're doing that kind of stuff. Does that make sense? So we have the ability
Absolutely.
now. There's this rural stabilization fund that's happened. But the one thing that I like about what's going to happen, I'm going to talk a lot about this on this webinar that we've got coming up, because I'm really excited about this, because now I believe we have now the horse before the cart versus we got the cart before the horse the last time. Many times we had the Centers for Medicare and Medicaid Innovation adopting models with different provider groups versus, and then people are wondering, well, how does that work with the state? If the state doesn't do something differently, how do we work with dual eligibles? How do we work with Medicaid? Do you know what I'm saying?
Mm-hmm.
But now they're putting this to where the states have to develop their plan, send it up for approval for the money to come down. Guess what? It gets incorporated now. Now it's the Medicaid, whatever. And so now CMMI could adopt something. Now you got the whole Medicare, Medicaid, and dual eligible population in there. So these are conversations that are starting to happen now. But who tells the story? It has to be, when we're talking about outcome data, it needs to be the data companies and the physicians. It doesn't need to be me. It doesn't need to be you, Butch. But we need to have people that have attitudes like you. That's why you're on my podcast, because I've known you for many years, and you know immediately when to say, I'm not the spokesperson for this. And you have enough humility in your leadership to say, you're the one that goes to the forefront. I might help you craft. I like to draft stuff. I like to write. I know how the process works. So I'm going to work with the lobbyists. I'm going to help draft and coordinate, but you need to talk. And that's why you're getting success. And so if you're not hearing anything that we've said today, and I'm going to let you leave with the last word and leave something for the people about what they should do and what has been the most successful, maybe give us one or two things that's been most successful with you. But if I can leave anything, is to listen to what we're talking about today. That sometimes our messages are right, but our voices are wrong. And so if we take and relook and rethink and retool the voices that we have at the table, maybe, just maybe, we'll win through this process. So wrap it up for us and give us one or two things for our audience.
So one of the things I appreciate, and I'm a registered lobbyist in Texas, and I know sometimes that has a certain connotation to it when you tell someone you're a lobbyist, but the days, and I know you can appreciate this too, the days where it's all whining and dining and slapped it on the back, those are gone. It is absolutely data-driven. And these folks want to pass something that's going to be meaningful, that's going to work, and the data is your friend. Find the data. And the most important thing, and I had an opportunity. Someone reached out to me from another state, and they don't have a strong state organization, and they weren't really sure how to go about it. Tell your story. Now, you might have to find the right person. Maybe it's a small rural provider. Maybe it's an urban provider. Maybe it's the doc. Whatever. But tell your story. And if you are not telling your own story, someone's going to tell your story for you, and you may not really like their interpretation.
Ooh, I think I'm going to leave it right there. I think Butch just made a pretty fantastic, I'm going to put that into some type of short on that. That was a pretty fantastic last piece. But thank you for joining the Leadership Lab here. Butch, thank you for joining me as well.
Thank you.